Also, like as I said, the webinar is being recorded. So if you do have any background noise that we might have, please go ahead and avoid some of that. Sorry, I'm fumbling my words. I had a few people ask me questions. So, but we are going to go ahead and get started. And I have the pleasure of introducing our speakers. Dr. Jennifer Anders is a pediatric emergency medicine physician at Johns Hopkins Children's Center in Baltimore, Maryland, and serves as Maryland's Associate Medical Director for Pediatrics. She is a native of Nebraska and a veteran of the U.S. Navy. Dr. Anders completed medical school and pediatric residency at the Mayo School of Medicine and her Pediatric Emergency Medicine Fellowship at Children's Memorial Hospital in Chicago. Dr. Jennifer Fishe is also joining us, and she is a pediatric emergency medicine physician at the University of Florida, Jacksonville, and the Associate Medical Director for Pediatrics for Nassau County Fire and Rescue Department. She received her MD from the University of Miami and completed her pediatrics residency at the Children's Hospital of Philadelphia and Pediatric Emergency Medicine Fellowship at Johns Hopkins University. Dr. Fishe is an assistant professor of emergency medicine and director of the U.S. Center for Data Solutions. Both speakers do not have any disclosure statements to make. And the objectives, as you can see on your screen, are the items that we'll be learning throughout the rest of this, the webinar. So that being said, I will hand it over to Dr. Anders and Dr. Fishe.
Thank you, Cassidy. Good afternoon, and thank you for joining us for this webinar entitled Optimizing EMS Destination Choice for Pediatric Patients. I am Jennifer Anders, a pediatric EMS physician from Maryland.
And I'm Jen Fishe from the University of Florida in Jacksonville, Florida. Over the next hour, we will discuss why EMS's destination choice for pediatric patients is part of quality pre-hospital care. We hope this will be an interactive and informative discussion, and we're looking forward to hearing a variety of opinions.
And we are very thankful for grant funding from HRSA and the Federal EMS for Children's program, acknowledged here. By the end of this session, we hope that you will understand how pediatric care is regionalized and how regionalization of care affects EMS systems.
We'll learn how secondary transport and over and under triage are suboptimal for both pediatric patients and EMS operations. Following that, we're going to discuss which non-trauma pediatric conditions are most likely to require inpatient or pediatric specialty care.
And we will introduce you to a pilot pediatric destination decision support tool for EMS providers, which incorporates that evidence base. Over the past 50 years, EMS has evolved from a system focused on rapid transport to one that focuses on advanced treatment in the field. We used to scoop and run, and now we stay and play. An enormous effort has been directed to creating evidence-based protocols for pre-hospital treatment. But that doesn't mean that transport isn't still a key function.
Hospital systems have evolved to where we have different levels of care. So now EMS has the critical role of recognizing which patients need those specialty centers and then getting them there. EMS still has the important role of recognizing also which patients are going to be best served by going to the closest facility for a faster turnaround and getting that EMS unit back in service for the next person who calls 911.
So the EMS transport decision is already widely protocolized for certain conditions where care is regionalized in a subset of hospitals and timely access to care benefits the patient outcome. For example, most agencies across the country have long had protocols directing EMS transport of adults with symptoms of an ST elevation MI to a cardiac intervention center, or directing adults with stroke symptoms to a designated stroke center. And for more than a decade, the CDC American College of Surgeons protocol has been directing patients with symptoms of major trauma or high-risk mechanisms of trauma directly to designated trauma centers. Pediatric specialty care is very similarly regionalized, but no guidelines have been widely adopted for the EMS transport destination decision for children. Which raises a question. Why do we not already have such guidelines? You can go back a slide, Cassie. Pediatric patients are less frequently encountered by EMS, only representing about 10% of patient transports in most places, and their conditions are less likely to be immediately life-threatening. So it's understandable that less research has been done in this area compared to the adult conditions mentioned previously. But we should not take that to mean that the transport decision is any less important. In fact, destination choice for pediatric patients can be considered the most frequent pediatric procedure supplied by EMS. It is certainly the most frequent opportunity that EMS has to impact the care of a child. Only about 25% of pediatric EMS calls involve providing any procedures or medications, including delivery of oxygen. And many fewer than that are critically ill. But 100% of children will require a destination decision if they're being transported.
And for about 40%, nearly twice as often as those requiring a procedure or medication, that destination choice is going to be bypassing the closest ED.
So some people will be asking, the local ED has great doctors. I trust them. They know their stuff. Why shouldn't I just take the sick kids there?
And while it's true that most EDs are ready for emergency stabilization, definitive pediatric hospital care is a different story. As we're familiar, and Jen just discussed, with adult conditions like stroke, MI, and trauma, not every hospital and ED is a center that can take care of those high-risk patients. What has happened in recent years is the same holds true for pediatrics, not just pediatric trauma, but also pediatric inpatient care, pediatric intensive care, and care of specialty pediatric conditions. So how much is pediatric care now concentrated in those specialty centers and children's hospitals? Researchers from Harvard actually measured this using the Hospital Capability Index, which represents the probability that a hospital can complete care for a certain condition. So this index is simply admissions divided by admissions plus transfers. A hospital capability index of 1 means that that hospital never transfers anyone out of their ED. They can complete care for everyone that walks in their door. A hospital capability index of 0.8 would mean that of all patients, 80% stay at that same hospital, but 20% have to be transferred. So let's see what hospital capability indexes are like for pediatrics and some common pediatric conditions in 4 states. Looking at data from hospitals in California, Florida, Massachusetts, and New York, those same researchers graphed out the hospital capability index for adult and pediatric conditions. All the orange boxes represent adult patients, and then all the purple boxes represent hospital capability index for pediatric patients. So you can see that for all of these 4 states, hospitals have higher capability indexes, meaning they can complete care for more adult patients. By contrast, very few hospitals seem to be able to complete care for all pediatric patients, and there are more pediatric transfers. Note that these states have very large populations, and in fact, California, Florida, and New York are 3 out of the 4 states with the largest pediatric populations in the country.
Let's pause to define a term, secondary transport. So when EMS transports a patient from a scene to a given destination, that is a primary transport. If that destination facility can't provide definitive care and needs to send the patient to a second facility, that's secondary transport. So we might ask, why is this issue so important to us as pediatric advocates? As the previous slide about hospital capability suggests, the need for secondary transport is not evenly spread across the age range. From our work in Maryland, which is very similar to the analysis from the Harvard group, we see that children are disproportionately affected by the need for interfacility transfer in general and secondary transport specifically. To quantify this disparity, children seen in EDs require transfer about 16 times the rate of adults.
Now looking back to the Harvard data on Hospital Capability Index, it's graphed out over time. Just for your reference, 2006 is their reference year for this graph. So it's not that in 2006 every hospital had a hospital capability index of 1. This just shows the trend in hospital capability index over time compared to 2006. As with the previous graph, the orange lines represent adult hospital capability indexes, and then the purple represent pediatric. This graph shows that over a decade ago, many hospitals were able to complete care for about the same number of adult and pediatric patients. But with time, hospital capability indexes for both adults and children have decreased, but much more rapidly and steeply for the pediatric patients.
So pediatric care is disappearing from local community hospitals. You may have noticed this in your area, either as an ED physician, an EMS medical director, maybe if you work in a community hospital, or especially in a rural area. Fewer and fewer hospitals have an inpatient pediatric unit, and even fewer will still take care of pediatric surgical or ICU patients. In an ED, you may notice yourself having to use interfacility transport for pediatric patients more to get them to definitive care, or that there are fewer in-house specialists to consult for pediatric patients. Hopefully we've convinced you by now that this is a real phenomenon. But many EMS providers may ask, what's the big deal? These aren't usually life and death scenarios. What's wrong with EMS just going local, and then they can always later do an interfacility transport if they determine that the child needs it?
Well, that would be a secondary transport, and there are important harms and costs associated with secondary transport, which we all should be aware of. We've identified through an in-depth study of secondary transports in Maryland harms and costs of this second transport. Secondary transport increases morbidity and adverse events, not just during the transport itself, but also afterwards. For example, during the transport itself, there's the risk of loss of IV access or even accidental extubation of a patient. And then after that transport, there's increased mortality and also adverse events in the first 24 hours for patients who are admitted to pediatric ICUs. There's also more handoffs, both literal. There's the physical loading and unloading of patients, which can cause some of those transport-related adverse events that I just mentioned. But then there's also the verbal handoff and reports that have to happen for a secondary transport, which introduce more opportunity for miscommunications and medical errors. Pediatric patients who undergo secondary transport are also less likely to receive adequate analgesia, both before and after the transport itself. Secondary transport also increases the likelihood of repeat or duplicate testing at the second facility to which the patient is taken. This includes painful laboratory draws, as well as exposure to ionizing radiation in the form of X-rays or CTs. In our study, we found that those X-rays and CT scans weren't additional imaging, they were repeat imaging. Finally, secondary transport delays definitive care. The patient must wait in the ED for their second ambulance ride of the day to get to a facility which can provide definitive care for their condition. This whole process is frustrating for patients, families, physicians, and EMS alike, and it's not safe and it's not family-centered care. Specifically with regards to time delays, secondary transport adds an additional 3 hours to the patient experience. It seems that, in general, the first ED providers in our study were able to identify that patients needed care in a separate facility, meaning that they didn't attempt to improve the patient condition for 5, 6, 7 hours before deciding to transfer. That transfer decision time was made, in the most part, within the first 2 hours of that patient's ED stay. But after that decision is made, there's an additional hour and a half on the median time wait for that secondary transport. And these times don't even include the time en route to the second facility. Beyond family-centered quality care and time delays, secondary transport and interfacility transport in general just costs more.
We compared costs of care for the top 20 pediatric diagnoses leading to inpatient admission and looked at total charges between multiple hospitals. For the same pediatric condition, if a patient must undergo interfacility transport prior to admission, the average charges are about 40% higher.
And we've just mentioned some of the reasons for why charges are higher: an extra transport, duplicate charges for emergency procedures, laboratory testing, and radiography, which also means that children are subjected to these painful and harmful procedures, and that there's an increase in the cost to the medical system.
Okay, so maybe secondary transport is a problem worth avoiding, but can we reasonably ask EMS professionals to triage pediatric patients to higher levels of care?
Well, it turns out EMS providers are already doing this, but they're using their gut instinct rather than an evidence-based guideline. We studied 3 representative EMS agencies in Maryland, including an urban, suburban, and rural agency. Together, these jurisdictions have almost 2 million citizens, about a quarter of whom are children. And I see that the slides didn't show our percentages, so I'll read those to you. So overall, the bypass rate for pediatric transports was 43%. In the urban agency, it was 32%. In the suburban agency, 53%. And in the rural agency, it was 59%. So currently, EMS was bypassing the closest facility with a pediatric patient nearly half of the time. Next slide, please, Cassie. Now, you might be wondering, how many of those bypasses are trauma patients? I know there's pediatric trauma protocols, so how many of those numbers should have bypassed the closest facility per protocol? So we took out trauma patients and examined the bypass rate for non-trauma alerts. Again, here overall, the bypass rates are pretty much the same. Overall in the 3 agencies, 43%, for the urban agency, 32%, for the suburban agency, 53%, and the rural agency, 56%. Take note of the bypass rates for suburban and rural agencies. While bypass for an urban agency may involve, say, an extra 3 to 5 minutes of drive time, for a rural EMS agency, some ambulances were traveling 20 miles further to get to a facility that could provide pediatric care. Think about this in the context of rural EMS. Those agencies are already stretched thin with workforce staffing issues and rely heavily on volunteer providers. Those bypass rates cause maybe the only ambulance crew in that area to go out of circulation for a prolonged period of time. Beyond those geographic disparities we documented in pediatric bypass, there also appears to potentially be socioeconomic disparities as well. In a study of Baltimore City, we found that areas with very high bypass rates, which you can see on the map on the left-hand side are shaded in darker colors, tended to have higher median incomes, as represented by the graph on the right-hand side of the page. And along the same lines, areas with low bypass rates had lower median incomes. Going back to bypass overall for children, for just those 3 EMS agencies in 1 year's time, non-trauma pediatric bypass resulted in over 44,000 extra kilometers traveled and over 1,000 extra hours of EMS crew time. To put this in perspective, in my home state of Florida, that 1,000 extra hours of EMS crew time is equivalent to about 777 average pediatric EMS runs.
So not only do we see evidence that EMS providers are already choosing destinations that bypass the closest facilities, we know that they want more guidance and tools to do a better job. And we know that because we talked to them. In a series of focused, in-depth interviews, providers told us time and again that they see it as a failure if they choose a destination and then find out that the patient later required a secondary transport. Next slide. They also told us that they need more transparency about hospital capabilities beyond the ED. Providers recognize that some EDs look child-friendly with cartoon characters painted on the wall, but that does not mean that they will provide surgical or specialty care for kids. Specifically, providers told us they try to use their best judgment to take children to a more pediatric-capable facility, if one is available within about 30 minutes drive time, particularly if the child has a severe presentation, prior medical problems, or if a parent requests a specialty facility. So by now, I think we've demonstrated a list of harms of under-triage when children are taken to a first destination and then later require secondary transport. These include burden on community hospital resources, duplication of procedures, higher costs, and lower quality of care, including both frustrations of delays and increased morbidity and mortality. And while these are considerable, that does not mean that every child should be taken to a big children's hospital. Over-triage is harmful too. When a patient is transported far from home without a need for that higher level of care, over-triage taxes specialty center resources. It creates inconvenience for patients and families, and it demands more resource utilization from scene transport EMS. And this is where triage tools come into play. You can click once, Kathy. To move that fulcrum to find a balance between the harms of over-triage and under-triage. The goal of matching patient needs with available resources is to maximize benefits to achieve the so-called iron triangle of healthcare, optimizing quality, access, and cost. So, we very fortunately got some funding from HRSA and the EMS for Children program and embarked on the Pediatric Decision Tree Project, the PDTree, creating and testing an evidence-based tool to guide pre-hospital pediatric destination choice. The project began by developing the preliminary evidence base. As we have described, we conducted a series of in-depth interviews with EMS professionals. In addition, we queried our statewide visit-level database to identify conditions associated with interfacility transport. And we conducted a case control study of risk factors for secondary transport.
We also conducted an extensive literature review to see what other people had found.
Oh my goodness, I don't speak this language. We used available statewide visit-level data from Maryland, and whatever language this is, it should read statewide pediatric transport data. We conducted analysis of the diagnosis categories that show highest numbers of interfacility transport after ED visits. These diagnosis categories group ICD-9 and 10 codes into bundles with broader labels, and some of these I know require a little explanation. For example, if you read closely, you may be questioning why there's a line labeled crush injury, but that includes a variety of ICD-9 and 10 codes related to blunt trauma to the chest and abdomen. So with this list, we began gathering a set of candidate conditions to consider for inclusion on a destination triage tool, those being the largest numbers for potentially affected patients. However, some of these conditions show up with large numbers of interfacility transport because they are very common. For example, from the prior slide, 300 children underwent interfacility transport for asthma, but out of how many thousands of asthma patients that were seen in EDs during that time? So on this slide, we looked at the same data but ranked the conditions by the rate of interfacility transport for each condition. Listed here, these are the conditions with the highest rate of interfacility transport after ED presentation. Many of them are relatively uncommon. For example, diabetes mellitus with complications. But when these children present to an emergency department without pediatric specialty capabilities, they have a very high level of requiring transfer out. Conditions like asthma and seizures, which are very common in ED presentations, have only a relatively small likelihood of interfacility transport, suggesting that a more detailed analysis is needed to determine if there are certain subtypes of asthma or certain types of seizure patients at higher risk for needing specialty level care. But in summary, this analysis suggested that these are the diagnoses most affected by regionalization of care.
Jim mentioned that deeper dive to determine what factors specific to certain common pediatric conditions could predict or are highly likely associated with secondary transport. So we took an in-depth look at secondary transport cases in Maryland that were initially taken by EMS to a local hospital and then underwent secondary transport to Johns Hopkins Hospital. We looked at the three most common conditions, which were seizure, isolated orthopedic injury, and asthma respiratory distress, and took an in-depth look at each of those patients. There were specific characteristics that had high odds ratios, meaning they were very associated with secondary transport. For example, tracheostomy care in both seizure and asthma respiratory distress patients was highly associated with the need for secondary transport. We feel that this is likely a surrogate marker of children with special health care needs, who probably have a range of subspecialists who take care of their conditions concentrated in a specialty or children's hospital. There were also some interesting factors related to likely what EMS was doing on scene that also were predictors of secondary transport. Those include administration of oxygen for seizure and asthma respiratory distress patients, also calling for online medical direction in orthopedic injury and asthma patients as well. This indicates to us that those EMS providers recognized on scene that these children were not straightforward transport to the closest facility and were requesting additional guidance for that destination decision. And finally, splinting of isolated orthopedic injuries, particularly of the elbow, was also a high odds ratio for secondary transport. During our literature search, we identified 60 other articles and studies for potential inclusion in our evidence base. 47 of those were included in an expert panel evidence profile, which we'll talk about in a few slides. We found some other conditions that were also found by other investigators to be high risk for secondary transport. And those included ALTI, which is now known as a BRU, apparent life-threatening event, or brief resolved unexplained event, seizures, as we mentioned, cervical spine injury, children with special health care needs, and then also a more objective EMS assessment, which was any abnormality in the patient assessment triangle.
So in summary, from all this preliminary work, we identified 17 conditions for which there is evidence to suggest that direct transport to a pediatric capable facility is warranted, either for reduction of morbidity or for avoidance of delays and other harms. 9 of these were medical conditions, including altered level of consciousness not associated with trauma, apparent life-threatening event, diabetic ketoacidosis or hyperglycemia, hypoxia, respiratory distress with an oxygen requirement, respiratory distress with tracheostomy, seizure where medication is administered, children who rule in for sepsis, and children with shock.
We also found there were certain traumatic conditions that were also associated with secondary transport, including eye injuries, femur fractures, other long bone fractures with obvious deformities visible on scene to EMS, suspected cervical spine injuries, and suspected child abuse. Additionally, as we mentioned, children with special health care needs that are having an exacerbation of one of those problems, and children with conditions that are receiving care for those conditions at a specialty facility who require ongoing treatment.
So with that list of conditions in hand, we began the iterative process of building the PDTree. We created an expert panel and held a series of online and face-to-face meetings and used a modified Delphi process to create the tree.
We presented the available evidence to a multidisciplinary group of experts, which included 3 emergency medicine physicians, 3 pediatric emergency medicine physicians, 3 EMS providers, 2 EMS medical directors, and a patient family representative. Prior to the first meeting of this expert panel, we conducted a round of online voting where panelists were provided a list of conditions identified in the literature and ranked them based on their experience as to which of these may likely require direct transport to specialty care.
We then held our first face-to-face meeting.
At this first meeting, the expert panel members were provided a template of what similar decision protocols for EMS looked like, and then we defined 4 levels of destination options for them to consider for certain conditions. So to create this pilot protocol, we had to match conditions to levels of pediatric care. In Maryland, as in most of the United States, there is no official pediatric capability designation for hospital facilities or emergency departments. Therefore, for this project, we created sort of a priori levels that could be applied to other regions, using pre-existing designations such as trauma or burn center, presence or absence of a pediatric ICU or pediatric OR capability, presence or absence of a pediatric inpatient unit or availability of pediatricians, and then all other local hospitals or freestanding EDs.
When our expert panel met, each condition was presented, and the panel was given a timed 10-minute period of discussion to discuss what the ideal destination would be for that condition. At the end of the 10-minute discussion, an electronic vote was held, and if a single capability level received more than 75% of the votes, it was accepted for placement on the triage decision tree. If consensus was not reached on the first vote, an additional 10-minute discussion was held. During that panel discussion, notes were taken about specifications or limitations the members felt were important for each condition. For example, here's the notes page for the discussion of altered level of consciousness. The panelists immediately wanted to exclude post-ictal children to reduce over-triage. And additionally, they very rapidly decided that age matters. We included these limitations in our first voting round, but did not reach consensus for children with a known seizure disorders. As you can see, the vote was split between a regional or a comprehensive level center. We did get consensus that children under age 2 without obvious seizure should be triaged to a comprehensive level center. We took these notes back to our committee with a post-meeting online voting round.
In this online voting round, we attempted to reach consensus for any remaining unresolved items and set that consensus at greater than 60%.
After those refinements, we held another face-to-face meeting. At that second meeting, we reviewed the draft in progress, with a key discussion being the time and distance limits for direct transport to a higher capability facility. This discussion was vigorous, but even in the population-dense Mid-Atlantic, panelists disagreed on what a reasonable limit would be. What is reasonable for an overburdened urban fire EMS agency is different than what is reasonable for a well-resourced suburban agency, and both are different than what is reasonable for a rural agency where even the closest hospital is far away. Not to mention how very different the normal distances and transport times are in big states in the heartland and west part of the U.S. So in the interest of flexibility and the interest of making the tree more adaptable to various geographic areas, the unanimous decision of the panel was to keep this open to interpretation by local departments and allow EMS professionals and their medical directors to determine what is reasonable in a given area or on a given day. And with that, our pilot decision tree was put for a vote and received unanimous approval from our panel. The final version appears here in the form of a poster or flyer which can be taped up in the back of an ambulance. The tool itself includes a guide to normal vital signs over the range of pediatric ages. This flyer also includes a guide to which local facilities fit into each pediatric capability category. And let's walk through the tree. So first, critically ill patients. Those in cardiac arrest, those with a need for emergent airway stabilization, which cannot be done by EMS, or those patients that may be recognized as needing specialty care, but where circumstances prohibit prolonged transport time, are directed to transport to the closest facility.
Next, we direct patients to pediatric specialty or trauma centers who have cardiac arrest with RUF, stroke patients less than 18, eye injuries, hand injuries, and burn injuries meeting burn center criteria, and those patients who also meet Maryland's trauma center criteria in general. Please note two things. We weaved in the existing trauma triage criteria because we didn't want providers having to reference two protocols for pediatric patients. And also, we left aviation up to the provider's discretion. The choice of aviation versus ground was beyond the scope of this project, but is important for future projects and validation of this tool. Next, based on the preliminary data we already discussed, children with special health care needs overwhelmingly require care in their home institution. Therefore, if possible, EMS providers are directed to transport patients to their medical home, the site of their ongoing care. Note that we specifically included wording that says emergency related to a known condition previously treated at a specific facility. For example, this would include a leukemia patient with neutropenia and fever. This doesn't necessarily include the same leukemia patient who's otherwise well but has pulled out their G-tube.
Children who are likely to require ICU-level care, or those who can be predicted to need pediatric medical or surgical subspecialists, are directed to a comprehensive pediatric center, defined as a center with pediatric ICU facilities, expecting that those same facilities are equipped for pediatric anesthesia, or OR. These conditions include children 2 and under with altered mental status who are not obviously post-ictal, children in shock with an abnormal patient assessment triangle, children with diabetic ketoacidosis, or children that are technology dependent with respiratory distress. Trauma conditions that do not otherwise get addressed by the CDC trauma triage tree include significant soft tissue wounds, elbow injury, long bone deformities, and femur fractures.
And finally, for transport to regional pediatric care, the protocol directs patients with an ALTI, seizures requiring EMS administration of a benzodiazepine, altered mental status without signs of trauma or seizure, respiratory distress with hypoxia or other serious signs, and sepsis and suspected child abuse.
And that leaves the remainder, children with none of the above concerns, directed to the closest open facility. So where do we go from here?
Well, we're currently pilot testing this tool in 3 Maryland EMS agencies and have some interesting preliminary results to share.
First, we put the tool to an online pilot test using 14 pediatric EMS scenarios. These scenarios were designed systematically to highlight key items in the PDTree tool. 7 scenarios described a case with BLS care only, and 7 required ALS interventions. A convenient sample of EMS professionals from the 3 Maryland jurisdictions were solicited to volunteer. For each scenario, 3 specific questions were asked. To which hospital would they take their patient in the current practice? Why did they choose that specific facility? And given the PDTree tool as a reference, what level of care is recommended by the PDTree tool? In this pilot test, we found that EMS was able to interpret the tool for the vast majority of scenarios, with very limited difference between BLS and ALS providers and between providers with longer years of practice compared to novice providers. In this pilot test, we did not identify any items that were misinterpreted and did not find reason to revise the tree, but we did identify areas to focus for education efforts, including recognition of orthopedic injuries, which will require specialty care, such as sedation or operative repair, diabetic emergencies, and handling of children with special health care needs.
After the provider online pilot test, we now are currently in a 12-month pilot test with the PDTree as a research protocol in the 3 jurisdictions shown here. We're collecting data on the PDTree tool usage, destination agreement with PDTree suggested level, and the effects on EMS transport patterns and operations. We expect to complete this later in 2019.
We have also developed a mobile phone application to make this easy and convenient for EMS professionals. If you go to our website, pdtree.org, you can find more information about the mobile phone application and the project. The app is available in both Apple and Android formats and can be found by searching PDTree in either app store. This app is free to use, and I invite everyone to download it and play around with it. If you have any feedback for us, the app allows you to provide it anonymously, or you can email me at emspdtree@gmail.com, or my personal email listed there. The hospital destinations currently loaded are limited to Maryland, where the pilot test is underway, and Central Texas, where the National EMS Physicians Meeting was held this year. Apologies to the rest of the country, but we have built the app and website to support future growth. We have the ability to add new hospitals to the list as new geographic areas may come online. And this is a screenshot of our website if you would like to learn a little bit more.
So our next steps include adapting the PDTree and validating it in a diverse range of locations, including urban, suburban, and rural agencies. Our goal is for the tool to adapt and be flexible, and to hopefully align with future pediatric capability designations.
Okay, it's about time to wrap it up. I hope we have convinced you that EMS destination decision is the most important pediatric procedure done by EMS.
And that's because pediatric hospital care is increasingly regionalized, which means that certain pediatric medical conditions now likely require a pediatric specialty facility.
In light of the acceleration of pediatric capability regionalization, EMS must adapt to the changing landscape and develop pediatric direct transport protocols. I would like to acknowledge the hard work of our other co-investigators and our expert panel members, and finally acknowledge that this project would not be possible without the vital support and assistance of Cindy Wright-Johnson, the PI of our Maryland EMS for Children State Partnership.
Jen and I thank you for your time and attention, and we look forward to your questions.
Thank you, Dr. Anders and Dr. Fishe. And we got a lot of great information and apparently a new language lesson as well. I guess it's just sometimes what happens when you go from machine to machine. Please feel free to put your questions in the chat box as I start to unmute everybody's line. So if you have a question, feel free to type that in and I will moderate. But I'm going to start unmuting everybody's lines as we speak. Anna says, cool tool. We all want to know, what do you imagine the requirements to have this include our state hospitals?
That is an excellent question. The place we are in Maryland is we are just embarking on our efforts to create official designations for hospital capability. It is
Dr. Fishe?
Yes, sorry, I think something happened with Dr. Anders' audio. I think what she was about to say was in Maryland, they're actively working on official pediatric level designations for all facilities. I can say for myself in the state of Florida, I'm the EMS pediatric medical director in Northeast Florida. And Florida is a very large, very heterogeneous state. And I think Florida is definitely not where Maryland is in terms of any type of official pediatric designations. That being said, I think for EMS medical directors and EMS leaders, it's important to know for each of us in our own jurisdictions what the capabilities of those different facilities are, and also periodically check and see how those change, because they do change, and as we showed in some of our slides, they're changing rapidly. And I think that regardless of official designations, it's the obligation of us to work those into protocols to recognize this changing landscape, because that's the reality on the ground.
Thank you for that. Do you have any other questions for Dr. Fishe, Dr. Andrews? Apologies, I'm not sure what happened with audio there. Okay, hearing none, I will conclude the webinar, and just with a great thanks to Dr. Andrews and Dr. Fishe for their time this afternoon. Definitely appreciate your time and giving us this presentation. The webinar will be recorded and placed on our EMSC website, as well as all of our social media accounts, so please feel free to share, and especially so that people can have access to that website, as well as contact information if they want to implement this tool in their local sites. But that being said, we'll give everybody of your afternoon. And again, great thanks to Dr. Andrews and Dr. Fishe for their time. Thank you all.
Thank you.